Good morning. Welcome to the Department of Medicine Grand Rounds. Today we have a special guest who's going to talk to us about asthma, but before that, a few words. On this day back in 1955 was the death of Antonio Egas Muñiz. Who was Antonio Egas Muñiz? Well, he was the founder of modern psychosurgery. He was a Portuguese neurologist who actually was one of the pioneers in cerebral angiography. But he's best known because he developed lobotomy, which required taking a sharp knife, put into the frontal lobe, took about less than 5 minutes, a very skillful or sometimes not very skillful operator, and for that you can win a Nobel Prize. And in fact, he with Walter Hayes won the Nobel Prize for this process in 1949. On this day also was the death back in 1931 of Gustave Le Bon. And Gustave Le Bon was a social psychologist, and he was the one who really worked out this concept that people in groups adopt a group mind, and that groups are emotional and irrational. He wrote that in a book called The Crowd, Study of the Popular Mind. But I think most relevant for today is back in 1893 on this day was the establishment of the first tuberculosis diagnostic community laboratory in the United States in New York City. Just 1 year later, in 1894, was the establishment of the first research laboratory in that area by Dr. Edward Livingstone in a room in the back of his home in Saranac Lake, and that later was called the Saranac Institute, which later became the Trudeau Institute. His work and that of others become very important for the establishment of the American Lung Association, which spins off later on the American Thoracic Society, and both organizations work very hard to address the dramatic problem of asthma. I will be leaving you soon today because I got to go back to the ICU where I have one patient with mild asthma who's currently in respiratory failure on mechanical ventilation in the intensive care unit. And hopefully our guest speaker today will give us some insights into how to handle that. So to introduce him, Dr. Rodney Foltz, who's the head of Pulmonary and Critical Care and Sleep Medicine. Rodney?
Thank you, Jesse. It's a real pleasure to introduce our speaker today, Dr. John Mastronarde from Ohio State University. In the last couple of years, we have developed quite a connection with Ohio State. We've recently had two new faculty come from Ohio State, Dr. Sean Smith, sitting back here on the left, in pulmonary hypertension, and Dr. David Nunley, one of our lung transplant pulmonologists. We have a new faculty who will be joining us in January, Dr. Gahar, who just finished his interventional pulmonary training at Ohio State. Anyway, let me just tell you a little bit about John. He completed his medical school at Ohio State. He stayed there to do his medicine pediatric residency, and then moved to Iowa to do his pulmonary and critical care fellowship training. He followed that up with a sleep fellowship at Oregon University before moving back to the Midwest in 2000, where he was assistant professor at Indiana University at the Indianapolis campus. There he was made the director of the Asthma and Allergy Center, and then in 2003 got recruited over to Ohio State to direct their asthma center there. John is also the director of the Pulmonary and Critical Care Training Program. He's a key figure in their translational core research in critical care program at Ohio State. And a year or two ago was named the Vice Chair of Education for the Department of Medicine. So as you can imagine, he's played quite a role in education. He's been the past president of the Association of Pulmonary and Critical Care Program Directors, involved in numerous program committees in our organization, the American Thoracic Society, mentored over 20 fellows or trainees over the last couple of years in a variety of different lung disease projects. In the area of research, he's focused primarily on asthma. He's got a number of research grants, which I'll mention here in just a minute, but he's been involved in everything from acid reflux in children with asthma. He has a asthma clinical research network grant through the American Lung Association. He's looking at the role of soy isoflavones and their role in asthma. He studied sinusitis and allergic rhinitis in asthma, and he will be speaking and has a particular interest on exercise-induced asthma, particularly with regards to athletes. And he'll speak on that topic at noon today in the Pulmonary conference room. As far as publications concerned, he's been very prolific the last 5 years, over 30 publications in the areas and topics that I just mentioned. So please join me in welcoming Dr. John Mastronarde, who will speak on an asthma update 2012. John.
Great. Thanks. Good morning. Happy to be here. Appreciate the invitation. I was getting a little nervous, and Dr. Roman was talking about irrational and emotional and how it fit with today. I'm like, geez, I appreciate that. And so today we're going to kind of go over, I'll give you my view on what the current update is on asthma. We've learned an awful lot about asthma, particularly in the last decade. There kind of be a common theme, the many faces, and if you remember one thing, there is no such thing as asthma. Asthma is not one disease, it's very heterogeneous. And we'll kind of go over that. I think you could summarize most of what we learned by just saying that. That's kind of where we are today. Where we go in the future remains to be seen, but that's kind of the take-home message throughout the whole thing today. So we'll kind of start as round round through the case, do a little brief history and prevalence, etiology. I'll focus mainly then on the phenotype diagnosis. We'll go a little bit over the guidelines. Everyone I'm sure is very aware. There's NIH guidelines, National Asthma Expert Panel that's met several times. And then kind of, they're a little old now. I'm sure they'll be coming up to be reviewed soon, but there's some things post-guidelines that have happened that'll probably get into the next set. So this is a pretty typical patient that we see in our asthma center at OSU. So she's a 42-year-old African-American woman who was referred for poorly controlled asthma. I'll give you a lot of these history, and then hopefully as the talk goes on, you'll see why I think some of the points are important, and we'll come back to her at the end. But she had asthma as a young child. She's never been in the hospital, never been in the ICU, but she's had a lot of ER visits in the past 6 months. She has pretty well-known triggers that she can associate. She kind of has the full gamut of symptoms. We'll talk about the attack a little bit later, but that's an instrument to measure asthma control. That's bad. Her short-acting bronchodilator, albuterol, doesn't always work for her symptoms. She's on Singulair. She doesn't know if it helps. She's got a whole bunch of usual other problems. Everything is pretty normal. She has some mild obstruction that reverses when you give her bronchodilator. Her ENO level was elevated at 80. 50 is normal, exhaled nitric oxide, which we have in our clinic. And her labs are unremarkable. Her IgE is 45, which I'll talk a little bit about later, which is within the normal range, but may have some significance for her. So kind of at this point, it's what do we do with her? What kind of testing should we do in 2012? So to step back to history, we've known a lot about asthma. It's been around for a very long time. The word itself is derived from the Greek words, but of course, like almost everything in medicine, Hippocrates was one of the first people to describe asthma. It seems like he described everything. It's kind of unclear if he meant it as a disease or a symptom, but I find it pretty fascinating that even then he pretty much really described occupational asthma and saw there were different occupations that were associated with whatever symptom or disease process that he was seeing. From there, asthma, we know currently has just kind of exploded. This is the CDC's data. The problem with this is they changed the questionnaire and the definition in 98 or 99, so the prevalences don't exactly match up. Depends on who you read, what number. 25 million people is roughly in the United States, about 10 to 12%. Here it looks like it's showing about 8.5 or 9, but it's going up. The attack prevalence is kind of leveled off. But more germane, I think, to this talk, and currently in 2012, is this part where there's a wide variety of asthma depending on your ethnic background, your race, etc. So we all know that little boys have more asthma than little girls. They hit puberty and it flips for the rest of their life. Women then have more asthma than men. We don't really understand why. Of course, there's lots of research about the sex hormones, but no one clearly understands why that is. But women have more than men. And then there are a lot of different ethnic prevalence changes. So blacks have more than whites. And then really the Hispanic population is getting more interest, and it's really quite striking. So Puerto Ricans, either in the island of Puerto Rico or when they've been transplanted to Brooklyn, still have a lot more asthma than anyone else basically in the United States. Mexicans have the least prevalence of asthma. So a lot of what we're trying to do now, I think, is figure out why, what's going on. Is this a different disease? What's your background that causes this? We know if you're inner city or you're poor, your asthma is worse or you have more asthma than otherwise. So what causes asthma? Well, nobody really knows. And again, probably because it's not a single disease. When you say asthma, you're talking about a whole spectrum of diseases. There are several theories. I'm not going to go over all of them. None of them are proven. All of them have, in some cases, very boisterous backers, but probably the one you may have heard of, or for the trainees in the group, the one you should know about at least, is the hygiene theory, which could really be summarized as dirt's a good thing for you. And then there are a whole variety of other folks who think that it's really allergens that drive it. Growing up near pollution or ozone may cause asthma. Anyone who's done any peds knows that there's a whole group of folks who believe that RSV or rhinovirus gives you asthma for the rest of your life. Genetics and a whole combination. So bottom line is there's lots of interesting areas. A lot of them are probably true, but there's no single clear etiology for asthma. So let's just talk a little bit about the hygiene theory. This was really hot, late 80s, early 90s. I think it's useful to frame some of what we know about asthma, but it's clearly not the answer for everything. So the hygiene theory postulates that everyone is born with a Th2 profile. I'm sure most of you remember this. So the Th1, Th2 refers to lymphocytes. In mouse models of asthma, there are lymphocytes that only secrete certain types of cytokines. That's where this came from. Humans are not quite so clean, but there does seem to be populations that predominantly secrete Th2 cytokines that you may be able to switch at some point. But so it's not as cut and dry as a mouse, but it still holds true. And mainly the Th2 is the allergic profile. So IL-4, IL-5 kind of increase and prolong survival via eosinophils. And there's a whole bunch that are classed here. These are the main ones that I just did for the slide. And the Th1 profile, which is really interferon kind of things. So the theory is that you're born with this Th2 profile. So you're kind of walking around primed to be allergic, primed to get asthma. And then if you get infections with things like viruses or other environmental stimuli, hence the dirt is good for you, you get a Th1 response. Interferon is really what responds to those things, and that causes a balance, and then you do well. This really was stimulated by several publications. The first one was in the early 80s that I remember when I was a fellow, came from Japan in Science, where they looked at people who either had TB or had the BCG vaccine and found they didn't have anywhere near as high a prevalence as asthma as someone who did not. I remember quite a few people just writing it off and complaining that it got published in Science and what did it mean. And it subsequently has been replicated in several other centers and kind of publications, specifically 3, I think, that were in the same New England Journal article that showed if you were a child and you had measles or mumps, you had less asthma. If you were a child with siblings, you had less asthma. And if you were in daycare, you had less asthma. Again, postulating that you in all those situations had gotten exposed to infections or other Th1-inducing stimuli and balanced out your Th1, Th2 axis. The absence of having that, so if you were a little kid who stayed at home and were an only child, then you kind of ran around with your Th1 profile. If you were in our protected homes where you didn't go out and play as much, you were in a nicely insulated house, you had a lot of indoor allergens, dust mites, maybe cockroaches, cats, and that kind of triggered your allergy. Your Th1 exploded, it was unopposed, and that's why you got asthma. So it sounds nice, it's a nice, neat little theory, there's lots of truth here, and it probably explains part of asthma. And again, I think it's useful to understand this allergic framework, but it's still just a theory, it's not really causal yet, and doesn't explain everything with asthma. So then, what is the pathogenesis, or what results in asthma? So as I've said several times already, it's a misnomer. In the clinic, when the residents or fellows work with me, they don't tell me a patient has asthma, they tell me what type of asthma the person has. I usually just say, you tell me the person has asthma, it's like saying they have lung cancer. That means nothing to me. What kind do they have? So they don't really have asthma. We know the inflammation in asthma is heterogeneous. It's not just Th2. Basically, every arm of the immune system that has been studied now plays a role in asthma. And then really where most of the recent efforts and breakthroughs have been kind of different phenotypes, and it depends on how you're defining your phenotype, but clearly there are different types of asthma that you can break down into different categories, and we'll go over some of that here today. So in some of the phenotyping in our center, as Rodney mentioned, we deal a lot with asthma in athletes and exercise-induced bronchospasm. We find it useful to kind of educate our asthma patients a lot. People who've lived with asthma their whole life have kind of ramped down. They just don't think they can do certain things. And particularly young folks, you have to kind of remind them they can achieve and do whatever they want. The majority of asthmatics can do whatever they want with our current drugs that we have. So we kind of trot out some people. Jackie Joyner's probably dated. I doubt many of the students or anyone know who she is from the '96 Olympics, but at one point she was the greatest female athlete in the world. She's become a big advocate for asthma. She speaks for the American Lung Association, talks a lot about when she was in college at UCLA, she didn't buy into her program, wouldn't take her meds, missed the Olympic trials, and then got on board and wound up excelling and winning the Olympic gold medal. So just to define things, because the other word that is now creeping into asthma lexicon is endotype, and I'm still not sure I understand what that means, to be honest with you, but as it's used, phenotype and endotype, so this is the definition from Webster's, observable properties of an organism produced by the interaction of the gene and the environment. We all remember that from medical school. Endotype is postulated now as the observable properties of a phenotype that are explained by its biologic pathway. So in asthma, people are trying to say, so this person is acting a certain way, like they have allergies, they respond to inhaled steroids, therefore that's a representation of their Th2 or allergic profile. I'm still not, I've heard several talks about this at the ATS and with several folks, and I think it's really kind of evolving, and I'm not sure I quite buy it yet or see that it's a very useful framework, but we'll see. I think as it evolves, maybe it'll turn out to be the term we're using. But you may see that. I'm not going to really talk about it very much from here on out, just to kind of introduce it as a term that's out there. Phenotyping clearly, though, is currently the wave of discussing things in asthma. So as I mentioned, there are several different phenotypes. It depends on how you phenotype them as to what you get. For most folks, there are clinical ones, so there are different spectrums of asthma for all of these factors. So age of onset, clearly pre and post 40 years old, people seem to act differently. Whether that translates into different responses, different inflammatory profiles is still to be sorted out, but there does seem to be people who act a little bit different. We all remember the old intrinsic, extrinsic, so atopic or non-atopic, do they have allergies? Very severe asthma seems to be a different animal than anyone else. There could be people who have mild asthma who have lots of exacerbations. That's a separate profile. Some folks who don't seem to respond to anything, or at least steroids. There are people that we study who just have exercise-induced asthma. They don't have asthma at any other time. And then, of course, the previously well-known, so aspirin-sensitive, Samter's triad, asthma, nasal polyps, aspirin sensitivity. And then women, more increasing interest in the fact that there are big sex differences. Women certainly perceive asthma differently. They may have bronchospasm at lower thresholds. And then there are some women who have asthma symptoms right at the onset of their menstrual cycle. Not everyone, but some do. So clearly there's some differences in the sexes in terms of both how they perceive and what underlies their asthma. And then if you look at serum sputum, so induced sputum is a lot of what we do in asthma. You don't like to bronch an asthmatic. They can have bronchospasm. You can, but sputum's a lot safer. So a lot of work was done in sputum in the 80s and 90s primarily. And so as I talked about, there's this allergic profile that's emerged. So Th2, high IgE levels, eosinophilic, people that are generally very steroid responsive. Then there's the flip side, the Th1, more neutrophils, people that are often steroid resistant, act a little more like COPD. Then of course there's those that are mixed and some that almost have no inflammatory cells. And those seem to be far and away the worst people. They don't seem to respond to anything. Exhaled nitric oxide, people are still figuring out how this fits into the world. We've been using it for a couple years, and I can't tell you I know exactly what to do with it every time. It adds some useful information. For a while, it was highly touted as this was the way to diagnose asthma. That is absolutely not true. It does seem to correlate very well with allergic inflammation, so it's an indirect marker to say, okay, this person probably does have a lot of eosinophils or allergic inflammation. I do buy that data is pretty solid, and we've kind of seen that. What you do with it in the clinic, I think, is still a bit debatable. We'll talk a little bit about the latest thing to come on board, which is really molecular kind of phenotyping. And in my mind, shows us the more we know, the more we figure out there is to learn. It kind of puts a different spin on the whole Th2 paradigm as well. And then, of course, the thing with the environment that affects all of this are the different cofactors: smoking, infections, pollution, obesity, that depending on what your underlying predisposition is, you start to have these different exposures and things can change quite dramatically. So clinically, the latest stuff out there is the cluster analysis done by the NIH Severe Asthma Program. So Wendy Moore at Wake Forest published this a couple years ago now, where they looked at over 700 people who were in their trials. Not all of these were severe asthmatics because they had different levels of asthma for some of their studies. And they tried to see were there ways to use cluster analysis to determine how asthmatics behaved based on different clinical, and they had sputum and other things at their disposal. And they found that they actually could identify 5 clear clusters that all of their asthmatics would fit into one or the other. There were severe asthmatics in every cluster, which again kind of re-highlights that our previous classification system was probably not the best, or was probably not specific enough. And initially they had 34 factors that separated these folks, but when they weaned it down, they found that 3 factors could represent over 80% of the patients. And those 3 factors were baseline FEV1, whether it was above or below 68%, whether they had big reversibility, so you give them 4 to 8 puffs of a bronchodilator, and did it go up over 110 or 108 or not, and then the age of onset, and again, within the people who had a low FEV1, did they have any response to bronchodilator? And they found 5 distinct clusters that all of the patients could fit in. And yeah, I'm hoping you could see this. So the different clusters, so mild allergic asthma, kind of early onset, normal lung function, little bit of sputums. The biggest one was kind of the biggest one that we know is out there. Mild to moderate allergic asthmatics are probably the largest population. So early onset, atopic, maybe their FEV1 was a little bit down, but it did reverse, did very well on inhaled steroids, and also had some eosinophils. And then the rest of the groups got pretty small, especially 4 and 5, but you can kind of read them there. Some of them were older. Obesity was a big problem for some of them. And then you get into the COPD, like lots of symptoms, lots of albuterol use, resistant to steroids. And then what I find interesting that they didn't comment a lot on is that there's eosinophils everywhere. So again, reaffirming that it's not just one type of inflammation or cell that's driving things, or cytokines, but in every single group there were some eosinophils. In one case it meant a good thing, those people responded to steroids. In another case it was a really bad thing because it means you didn't respond to anything. So we still have a lot to learn, but this has been pretty interesting. It's been replicated in a couple different populations now, and it's kind of gaining traction as kind of one of the new ways to look at lots of clinical factors to see if we can group our asthma patients, with the hope that if you can have something that's able to be done in the clinic, then the next step here is to see, well, do these clusters respond differently to medications, and how should we treat them? And then just briefly, the molecular phenotyping that I mentioned. So this is a couple years old now. So Prescott Woodruff at UCSF published this, where they did do bronchs on asthma patients, endobronchial biopsies as well, and looked at different genes that basically were markers of IL-13 or a Th2 cytokine. And they found, when they looked at it, that not only was there Th1 and Th2, but there was Th2 low and Th2 high. So some people had a Th2 profile, but it wasn't very active. It wasn't turned on. And if you looked at them, their gene expression was kind of just like the normal controls, which was very interesting at the time. So you can't really see that. There's little healthy controls, little A's, and the Th2 highs were there, which I think by itself would have been interesting. But then they also had a sub-study of patients where they gave them inhaled steroids, and the only people that responded to the inhaled steroids were the ones who had Th2 high expression at that time. The lows, I don't know if they really got worse, but they really were no different than the controls. So this kind of, at least I think to most people, started to highlight, well, you can have Th1, Th2, but there may be some things that turn it on, turn it off. Maybe it's inflammatory milieu. May explain why if you're walking around with Th2 and you get a viral infection, things explode. So I think, again, there's a level of complexity with some of the underlying inflammation that we're a little limited on yet and don't completely understand. And then what about genetics? If we're talking about different individualized treatments, of course, there must be different, or diseases, there must be different genes. A lot of work, as you can imagine, has been done in this, and asthma really hasn't come forth yet, mainly because, again, all of the studies have been looking at different phenotypes. And in my own mind, when I look at studies, particularly from, I guess, from older than the last 3 or 4 years, you really have to look at asthma clinical trials now with an eye of who are these patients they're studying. Because they were probably studying various forms of asthma that at the time we didn't really recognize. So when you read those papers or read recommendations, you need to look at who is this population and is this that person that's sitting in front of me in clinic or not? Because it may not be. And the same thing was true of the genetic studies. So clearly we need some better studies with well-phenotyped, well-defined populations, which are ongoing but aren't there yet. I don't pretend to know much about genetics, but there are a couple different ways to do it. GWAS, or genome-wide association studies, are the current hot topic in the genetics world. There have been several things identified for asthma. ADAM33 seems to be a pretty consistent one that's probably linked to airway hyperresponsiveness. Probably the only thing I think that really most people are firm on is this gene in childhood asthma seems to be pretty consistent. There's a Tucson birth cohort where they followed babies from birth in all of Tucson to see who developed asthma and trying to compare them. And then there have been a couple other similar studies, and they've all kind of landed on this same gene pair that does seem related to childhood onset asthma. So again, there's lots to be done, but there is no current asthma gene in 2012 that I think you get anyone to agree on. And then of course things get more complicated because of what people do. So if you are a so if you're in that cluster 2, mild allergic asthma, high eosinophils, Th2, you should respond to inhaled steroids. But you know, if you smoke, that inactivates inhaled steroids. Inflammation gets much more resistant, neutrophils don't die, it inhibits apoptosis, so maybe you don't respond as well. And then what do you do with that person? The bane of anyone who takes care of people with asthma are cats. Cats are little and cute, everyone wants to sleep with them. If you're allergic, your asthma will never get better. And I do not tell people to get rid of their cats. They will never come back and see me again. I used to tell them to wash their cats, and they kind of figured that out pretty quick. Now, I just say, well, you know, here's this. You're not going to get 100% better. This is probably as good as I can get you. Is this as good as it is for you to have your cat? This is the trade-off. You live with this level of symptoms, or you get rid of the cat. They all keep the cat. They all sleep with the cat. There's just nothing you can do about that, you know. Thank you. And you know, so then there are other issues like if you live in the city, lots of pollution, ozone, etc. Car exhaust seems to be a problem. We talked a little bit about viruses, RSV, rhinovirus. Lots of little kids get RSV. Some kids wheeze and get better. Some kids wheeze and get asthma. Why? We don't really know. And then dust mites, and a lot of people allergic to dust mites, cockroach antigen. So if you're not doing environmental controls, that could trigger more inflammation irrespective of what your underlying profile is. So all of this makes it pretty complicated to sort out, I think, for us as a clinician, how to phenotype, what's the best way to deal with our patients. Just to go back to history a little bit, I find this incredibly interesting. So in 2012, the current hot edge is that asthma is different, it's not a single disease. Well, Sir John Floyer, who was English, wrote the first treatise or treatment on asthma in 1698 before there were stethoscopes. And he was on the edge because he said it was due to bronchoconstriction and not due to bodily humors. Phlegm was the bodily humor that was thought to cause asthma. People were thought to be sitting around producing lots of phlegm, very slovenly, kind of lazy folks. He kind of went against that, said it was bronchoconstriction, and actually recognized there were several species based on clinical history. So in 2012, we think we're pretty smart, but this guy without a stethoscope or no real microbiological analyses had figured out the same thing we did, that a good history can tell you that there are different species of asthmatics. Then we can do some of this in the clinic. How that translates into our treatments is still a little bit soft, but I do think it's still a good exercise. So getting with that, what do we diagnose? So this is why asthmatics can't breathe. So Dr. Roman unfortunately has every pulmonary critical care person's nightmare, which is an asthmatic on a ventilator. It is one of the few diseases the ventilator does not help an asthmatic and can kill it. Kill him or it. So it's really when you have an asthmatic patient on a ventilator, you don't sleep very well and you're not very happy because it's a very dangerous situation for them. And so this is the end airway looking through a bronchoscope, probably right middle lobe maybe, we'll say. They all look the same, you gotta know where you were. So it looks nice, it's open, the mucosa is all nice and pink. And this is probably a person allergic to cockroach or some similar antigen. It's a research study. You shoot down that antigen and then take pictures. And this kind of is what happens 10 minutes later. Pretty dramatic effect of asthma, but it's pretty close. So with an asthmatic, when they flare, they get lots of edema, lots of swelling, lots of mucus production, and that's kind of from there what they're left with to breathe. So that's why asthmatics are pretty short of breath. They do produce a lot of mucus, as I said. This is an unfortunate autopsy slide, but you can kind of see this is the really thick mucus that's basically clogging their airways. And if you look at that even further, this is a cross-section. This is that airway just full of stuff, dead cells, mucus, lots of inflammation with the eosinophils. But in this case, this is another subpopulation I didn't talk a lot about, but that COPD profile. There are people who have very thick basement membranes. So this is much thicker than it should be. This should be one cell, and it's obviously bigger than that. They seem to have fixed airway obstruction. They don't reverse. And so that's another subpopulation of patients. Not everyone does this, and we're trying to figure out why. But this is obviously the downside of what happens when asthma flares and you can't control it. So in the clinic, what can we do today about these phenotypes, or how should we be looking at patients? So really, you want to know, when did their asthma onset? Again, childhood versus adult seems to be different. How often are they having exacerbations? That actually may play a key role in your treatment. Whether they're in the ICU or intubation, single biggest risk factor for fatal asthma is a previous visit to the ICU. Somewhat surprisingly, when people get discharged from the ICU or intubations from asthma, they become very non-compliant. It's pretty well replicated. It's very unclear. They almost have PTSD. They just develop a fatalism and quit taking their drugs. So the single biggest thing when you have an asthmatic in the unit or after they're extubated is their follow-up and really trying to get on them for compliance, because that's who comes back to the ICU. Remember, asthma is an episodic disease. It's not like COPD where they have symptoms all the time. It's a bit of a problem. When asthmatics feel good, they quit taking their drugs. So you have to kind of be aware of that and be bringing that up. They have a variety of symptoms. We know asthmatics just don't all wheeze, particularly adults seem to. What happens is important to ask them. So you get an attack, what do you do? How quick does it go away? And then there are things that if you don't ask them, they're probably not going to bring up to you. Like what are your triggers? Is it smoke, cigarette smoke, perfumes? I usually ask them when you walk through the department store, do you have a problem in the perfume section? Dust, mold. A lot of people just don't think about this. Their asthma's flared. And then in particular, if they take any aspirin, non-steroidals, they often don't figure that out. There are metabisulfites in beer and red wine. And I had a woman from a suburb where Dr. Nunley used to live in my clinic last month, who was upper middle class, whose response was, oh, that's why when I have my six-pack, my asthma really flares up at nighttime. So lots of people drink. They drink a lot of beer and red wine. You don't bring that up. They don't know about it. And certainly cocaine. In the inner cities, Cook County published several years ago that one of the most common reasons for asthma attacks was use of either smoked or inhaled cocaine. And then the allergy history, tobacco abuse, 25 to 30% of asthmatics smoke. It's really a bad thing for them to do that, but that's a pretty consistent number as well in most of the studies. It's pretty important to ask how the asthma is affecting them and what they hope to accomplish if you really want them to buy into your treatment. Like lots of things that are published, doctors are still very hesitant to ask patients about sex and how their disease process affects their sex. With our electronic record, that gives you the advantage to have kind of templated notes, so all the residents who work with me kind of use my note. That question's on there. They're a lot of times very surprised at how much of an impact this has on patients' lives. And when you bring it up, they really don't do anything, and it's not a very hard thing to treat, right? It's exercise. You just say, it may not be that sexy, but whip out your albuterol 10 or 15 minutes before you're in the mood and hit it, and maybe things will go a little bit better. But just opening that question and line of communication, I think, is important. Family history and then review of systems. we'll talk a little bit about some of these things that can either, we think, worsen their asthma or like GERD, kind of mimic their asthma symptoms and fool you a little bit. In the physical exam, you do an exam on an asthmatic patient to look for something else. There's nothing that on the physical exam is specific for asthma, but you don't want to miss something else. So most things are, there's no one test. Most things are completely normal. Everyone should get spirometry. Oftentimes it's normal. Some people are very dogmatic and like airway reversibility. I'm kind of in the middle. I don't have to see that if everything else fits. There's not really a right or wrong way there, so it just depends on your practice. Methacholine challenge testing is very non-specific. 8 to 10% of the population will have a methacholine that's positive. If your patient's on inhaled steroids, it may be falsely negative. So I don't use a lot of methacholine unless I don't think this person has asthma, and then it's another piece of information. If you're dealing with any type of legal issue, the lawyers will crush you if you do not have a methacholine though. So that's one case where you have to get it. But it's kind of plus minus in my practice. The data is a little bit all over the place. So there's a whole variety of things that can act like asthma, we know from medical school. We're not going to talk about a lot of these, which you're all pretty familiar with. I will just say, dealing with referral population of asthmatics, where I've gotten kind of burned or fooled the most has been tracheomalacia. So people who have severe asthma who are just not responding, I would urge you to suck it up and bronch them, because I've been pretty surprised that that's what's going on. I don't have a good treatment for it, but I quit bashing them with steroids because that's not what's happening. So I've gotten burned a couple times on that with patients that I just really didn't think about until almost kind of fairly on down the road. And then vocal cord dysfunction, I'll just talk a little bit about. This has been around for a while. Columbus, Ohio seems to be the VCD capital of the world for whatever reason. I don't know if it's the way we diagnose it, but I've seen more VCD than I have ever seen in my life. So there's obviously this one of our ENT guys. There's the vocal cords wide open, air's coming in. This is a patient during inspiration who has vocal cord dysfunction. This is called the posterior chink. So you go from that airway to that airway. So they get very short of breath, originally described as psychosomatic asthma in young, anxious women in the ER, has now been seen across the board. Also in athletes, our wrestlers have the highest prevalence of this. So people that get pretty amped up and anxious for things start to get short of breath. When you're taking a history and people say that stress triggers their symptoms, we know stress can trigger asthma, but this is probably more what we were seeing and we didn't realize it. When their albuterol doesn't work all the time, that rings bells up for me. And then particularly, what do you do when you have an attack? A lot of folks with VCD just kind of, they'll say, I just relax, or I just stop what I'm doing, and it gets better in 2 minutes. Well, that's not asthma. You can't will your asthma to go away. So those are kind of the things that we look for in the clinic that tip us off. It is a pretty important diagnosis to make because you treat it primarily with speech therapy and relaxation techniques. In a lot of cases, once patients realize this is a vocal cord problem and they are not going to die from their asthma, it gets better. They just start to relax because it feels for all the world like asthma. Sometimes you get lucky and they'll point to their throat and say, I can't get air in. That pretty much makes the diagnosis for me. Our athletic trainers now at Ohio State on most of the teams will listen to the athlete's vocal trachea, and I get a couple referrals with short of breath out of the pool, head stridor over his trachea, he's got VCD. And so I'm pretty happy about that, and they're always right because he does. Particularly though, to make the diagnosis, we worked a lot with ENT. They're used to looking at people's vocal cords for other issues when they're just sitting there. That is of no value in an asthmatic or a VCD patient. They have to be stimulated. So with the athletes, they bought a recumbent bike. They'll bring out perfume, light a match. I tell patients, you're going for this VLS test, do not leave unless you have symptoms. Because if they look at your vocal cords when you're sitting there, I don't care. That doesn't tell me anything. You have to have your symptoms so they can see if this is going on. I think that may be why we diagnose so much of it, but one of the residents looked at our patients the last couple of years, and about 30% of our asthmatics also have VCD. So it's a pretty important thing to look for. In the standard diagnosis or the NIH, so again, expert panel, I'm sure all the primary care folks have read all 404 pages and committed it by heart. We wonder why people don't follow guidelines. I haven't read all this. It's really a big document. It's got a lot of great stuff in it, but not that useful, I think, in primary care if you're trying to get people to read it. Phenotypic therapy is not yet a reality. It's 2007, so it's getting a little old. Kind kind of needs updated. And the last revision I'll say is all the mild, moderate, persistent asthma that people used to get taught is pretty much going away. Again, we realize that's not a very sensitive classification. It was really only for initial presentation anyways. Nobody used it, so that's kind of faded to the background a little bit. The current emphasis is on assessing your patient's asthma control. How is this affecting their life, and are they controlled or not? So this was the old, or still the table of severity that they kept in there, but really said it's for research anymore. So I'm not really going to talk about this, and I don't make people classify by severity anymore in my clinic unless they're refractory. Most of the focus now is on control, which is very similar. So you're either well controlled, not well controlled, or very, very poorly controlled, which means you have symptoms all the time. Well and not well controlled kind of are corollaries to the old severity. It's really the rule of twos. So do you have symptoms more than twice a week? Do you wake up more than twice a month? Do you use your beta agonist more than 2 times a week? So if they violate the rule of twos in any of those, they are an uncontrolled asthmatic. And then lung function puts you into different frameworks. It depends on whether you can fix this or not. You can have a low FEV1 and be well controlled if you don't have any of your symptoms. This is kind of for initial. And then there's several validated questionnaires that they advocate using to measure asthma control. Because if you ask most asthmatics, are you doing pretty well? They'll say yes. But if you ask them specific questions, you find out there's more impairment than they realize or that they want to admit. There are several that have been validated. The attack is one. I have a slide to show you what that is. It's 4 questions. We use that one in our clinic just because it was one of the first ones out. There's also the ACT, which is now passed out by the American Lung Association, was originally developed by Glaxo. That's why it's got a purple Advair background. It works pretty well. It's also very simple. The ACQ is Elizabeth Juniper's kind of proprietary item. You have to pay for that, so we don't use that so much. But so they're all out there. One of them is what you should be using. It's a PQRI measure in Medicare for assessment asthma control. It's an easy way to get your credit. You have the patient fill it out while they wait for you, and then you look at it. They put in risk, again, to try to get at this phenotype of people who have lots of exacerbations. And again, sticking with 2, they said more than 2 a year. And they kind of give you some idea on when you should step up or step down people, which I get questions a lot, usually 3 months. So if somebody's doing great and they're on combination therapy, for example, after 3 months, I talk to them, and then that's the time when I'll say, okay, let's start weaning you and see what happens. But you want people pretty well controlled for 3 months before you make big changes. This is the attack, just to give you an idea what it asks. There are 4 questions. Any yes is a problem. If they use more than 12 puffs of a beta agonist in one day, that's the yes for that question. Pretty well correlated. If you get 2 or more, your increased healthcare utilization and poor asthma control. This is the ACT. It's kind of the reverse. A high score is good, but otherwise it's 5 questions. This one is pretty widespread. It's pretty, the ALA can get you a whole bunch of copies, or you can go to the Medscape, anywhere you can get this for the clinic. So it's something that's pretty readily available and you can get for free. So just when I talk about treatment, remind everyone that it's not just drugs, and particularly in asthma. So we talk about control, but really education with patients, figuring out what do they want, what do they think about their asthma. Most asthmatics have lived with it their entire adult life. They know their asthma. If you're not aware of what they think is going on, it's just not going to work. So you have to figure out what have they been doing, what do they want to get out of this. And a lot of times I tell the residents it's really negotiating versus caring for an asthmatic. You got to come to some agreement on what are we going to do here. And then environmental factors and comorbids we talked about. Tobacco cessation now is a big one. I find it useful to go over with people, here's my goals, which that you should be totally normal on as low a dose of drugs as we can get. And then we kind of figure out what they think, or they think that's going to happen or not, and then it kind of helps me to go from there. So everyone knows there are 2 different types of asthma medications in terms of classifications. So quick relievers, beta agonist, albuterol, or ipratropium, or combination of those 2. And then the litany of long-term controllers. I'm not going to go through all this in detail at all. Just kind of highlights on a couple things. So inhaled steroids are the go-to drug for every phenotype right now. Even the resistant ones, you start with inhaled steroids are the current recommendations. That's the best we know at this point in time. A lot less side effects. There are some, but certainly a lot less than oral. And this is, I have a friend in primary care who will taunt me and say asthma is just an Advair deficiency, doesn't really understand why anyone spends any money on it, just give them 250/50 and they all get better. Absolutely almost makes me seize every time. That is very common. Not everyone needs combination therapy. So when you see a brand new asthmatic, put them on low-dose inhaled steroid. There's a whole bunch, pick one. Any of them are just as good on the new generation, and then see if they respond or not. Not everyone needs the, well, in some cases, $120 combination therapy, but that's kind of what happens. And so these are the steps that I'm sure everyone has seen before. So you start with low-dose steroids. If they're getting worse, then low-dose steroids plus LABA or medium dose. So I didn't talk a lot about this, but I'm sure everyone's heard about the controversies with long-acting beta agonists, that in some patients they may worsen asthma exacerbations and increase death, and particularly African Americans, from the GlaxoSmithKline SMART study, or the DUMB study as everyone calls it, an incredibly poorly designed study, that then they wound up with this trend in increasing deaths and got a black box from the FDA. Now there's a lot of other data on other LABAs that cause some concern for the FDA, and I almost think they have no choice to do this, but in combination with an inhaled steroid, there's no data that LABAs are dangerous, and there's lots of data that this helps people with asthma. But you need to be aware of it if you're going to add this to a patient, particularly an African American. People have lots of access to the internet, and they'll come in and ask you why you're trying to kill them with those drugs, which I've had a couple people do. So you have to have the conversation. And in deference to that, they went to medium dose. There's good data, low dose and LABA is better than that. But I think both of them are, there's again, nothing right or wrong in asthma. So that's kind of why that recommendation is there. If they still fail and you get to medium dose steroid and LABA and they're still having symptoms, there's not a lot of data after that. The evidence kind of drops off. There's little studies, but no one can really tell you what to do. And that's where you get back to the art of medicine and figuring out all these phenotypes and picking a drug that'll work. You have lots of options, leukotriene modifiers. If they get to high dose and fail and they're allergic and they have an IgE level greater than 30, so allergic, they have to be allergic to a perennial allergen. So not like pollen, they have to be allergic to cat or dust mite. Then they can get Xolair or omalizumab, which is a monoclonal antibody that binds circulating IgE. You get a shot either once a month or once in 2 weeks, depending on your weight. We have almost 25 people, I think, that we put on this, and every single one has responded. I think there are a couple of reasons. A, we stick very specifically to the data on the studies and pick those patients. And then in probably half of them, I guarantee you it's because it's directly observed therapy for asthma. They were non-compliant and now they get a shot. So you can decide it's about 10 to 15 grand a year. Is that cost effective? It keeps them out of the ER in the hospital? I'm not sure, but that's why it works for a lot of people. They do have to get therapy, but it is a good agent for people that are that meet the criteria. What we don't know now is do you have to use it forever? Nobody can tell me when to stop it. There was a very annoying trend for increased malignancy in some of the studies that I don't use it in anyone who's got a history of cancer, and make sure everyone's aware of that. So we still need some data, but it's a nice option for people. And then just to kind of finish up, since the guidelines, there have been a couple things out there. So there have been a couple publications in the New England Journal now showing that tiotropium or Spiriva can't help some asthmatics. The first one was done as a non-inferiority, so not a superiority study, mainly because there were concerns, well, Spiriva supposedly has cardiac side effects. Is this dangerous to give asthmatics? And this study said really there weren't any concerns. It was not dangerous. This was a much bigger study, or at least a bigger study. They excluded people with cardiac disease. I'm not sure why they did that, but that kind of compromises this a little bit. But if you have someone with, so a younger asthmatic without cardiac disease who isn't doing well on a steroid and LABA, who has lots of exacerbations, adding Spiriva does have some data behind it. It may make a difference to that. Unfortunately, it didn't make their symptoms or quality of life better. You know, and it's an expensive medicine, so you're really going to have to fix that person for them to buy this. But if they're going to ER a lot, this may actually help. Macrolides, so the folks at National Jewish have touted that in some people asthma is an infectious disease. There have been several studies that show chronic traces of chlamydia or mycoplasma in lungs of people with asthma. Seems to mainly be a North West phenomenon. Not everyone can find this. And that started them to put a lot of people on Biaxin chronically to see if that improved it. It's transitioned to azithromycin, which we now know is the miracle drug. Is there anything that azithromycin doesn't fix right now once a day? So we're using it for lots of things, including COPD. So now it kind of translates to that. Those also have anti-inflammatory properties. So the debate is it really a different level of inflammatory inhibitor, or is it's antimicrobial? There was a study by the NIH's asthma network that at least in 90 people with mild or moderate asthma, it didn't work. So that kind of says it's not for everyone. So who do you use it in? Well, I use it in people who are refractory, who are acting to me like they're neutrophilic, meaning they're refractory. They're not responding to inhaled steroids. They're still having a lot of symptoms. I can't fix them. I can't find any other comorbidities. I've given some people now daily azithro. Started with 8 to 10 weeks. Most people don't want to stop it because they feel better who respond. It's probably about 50-50, the people that have and haven't responded. So it's something to try in some patients that you don't have a lot of options on, which is kind of also where thermoplasty fits right now. Got a lot of publicity, still getting a lot of publicity, burning your airways. So you go through the bronchoscope, put out this little catheter, it just touches the airway, delivers thermal energy, kind of microwaves. The theory is it heats it up and decreases the smooth muscle, so you get rid of the twitchiness. Pretty safe, which is what gave most of us, when they first presented this, I remember being at the ATS and I'm like, are you kidding me? What? You're crazy. And out at least 10, 15 years now, people do not have long-term side effects. It didn't seem to scar their airways like we were all worried about. You do 3 lobes, you don't do the right middle lobe because that's a little narrow already. Got to do 3 treatments, 3 weeks apart. The initial randomized study looked great. It was a decent size. People's quality of life got dramatically better. It actually seemed, okay, maybe we can cure asthma in some people. They came off a lot of their drugs. And then, most device trials now, the FDA demands a sham study. So in this one, they did everything except turn it on. They even made the same noise. It's got this little buzz. And there was really primary outcome was quality of life. They found no difference at all. The only thing that saved this and continued is that in people who had severe asthma with airway hyperresponsiveness, with lots of exacerbations, people we talked about hitting the ER a lot, it had a dramatic effect on them, like 80% reduction in ER visits, which would be huge for that person, their quality of life in terms of working and healthcare utilization. So that's what's gotten it continued to go. The FDA has now mandated, post-marketing studies. Let's look at all this. We've done about, I think, a half dozen now, and so far, well, one woman I'm not so sure is completely with it, but she thinks that everything is great. We have one of our bronch techs whose asthma is dramatically better. He was very severe, and he is dramatically better after this. So I think it may be an option. Again, you have a group of people that you don't have a lot of good data or treatments for, so we're kind of reserving it for them. I've had a lot of people who show up with mild asthma who want the cure, and we won't do it on those people. So there needs to be some more data, but it is kind of an interesting thing. We're running out of time here. So the cytokine blockers, so blocking this cytokine inflammation really hasn't worked, at least across the board. Some people maybe had some exacerbations, but really thought it would work a lot better than this. There's still going to be some more studies, picking the right patients, I think, but right now, at least in my opinion, it's been a little disappointing in the effects of that. Lots of alternative agents. People do herbals. Vitamin D we know is low in people with asthma and little kids. There's a big NIH study looking at supplementation. Our network just finished our study looking at soy supplements. We'll see what that showed. I don't know the data yet. There's not a lot of data on looking at exercise, an interest I have as a therapy for asthma. And then lots of asthmatics use different alternative medicines, alternative therapies. It's good to ask. You will turn them off if you dismiss them. If they have vocal cord dysfunction or if they have a lot of stress in their asthma, yoga, some of these other things probably do work for them. So I just make sure I'm aware of what they're doing and try to reserve my judgment on whether it'll work. So in our patient, here were some of the highlights that I hope I've kind of gone over as to why these things were important when we were looking at her and what did we approach her with. So we kind of decided she was poorly controlled, mild to moderate, asthmatic with allergic phenotype. Her clinical history bothered me a little bit for VCD, But out of the box, we just gave her a low-dose steroid. We have a phenomenal nurse practitioner who does most of my work in the clinic and fixes people with really intense asthma education therapies. She came back for follow-up. Her spiral normalized. Her E&O had gotten much better. So to me, the inhaled steroids are working. Wheat-centered allergy. She had positive skin tests to a bunch of things. They put her on environmental controls and antihistamines, but she still had some ER visits. And most important to her, she missed work. In current economy, you can't miss a lot of work. You get fired. So this is a big deal to her. She was still poorly controlled. Because of these histories, she had a BLS, she had VCD, they have speech therapy there, works with them right away. When she came back, she was one of our successes who got a lot better. Her attack score was normal. And it doesn't happen that often, but some patients can start to tell the difference. Oh, this is my vocal cords, this is my asthma. That's great when that happens, and she was one of those. If she continued to have symptoms, then we would have bumped her up on combination therapy. Leukotriene modifiers work, I just can't tell in who. It's about a 50-50 shot. She had rhinitis, so montelukast might have been a good option for her. And then as we talked about, Xolair down the road. So in summary, asthma is a major health problem across the world. We've come a long way since Hippocrates and understanding it, but we still have a lot more to learn, I think, about what are the true phenotypes and what underlies them. And then the next frontier is to kind of figure that out and then see if there are different personalized or identifiable treatments. So what do you do right now in the clinic? So as I kind of alluded to, focusing on the history, figuring out how this asthma is compromising this person's life so that you and the patient can come up with a way to treat it. Look for other comorbidities and medications based on control, kind of ignoring the severity for the most part right now. And then with all this stuff in the current high-tech world, the basics are still true. Technique, we're still using inhalers. People still don't know how to use them. Spacer devices should be used with all of them. My nurse practitioner has an idea that we haven't put into a study yet, but people with Malapati 4, so big floppy airways, don't do well with any of the powders. So we switch all those people to HFAs. So there are little things you can pick up that maybe or maybe don't work. Cost is a big one. All of these things are expensive. If they can't afford it, they're not going to take it, and they probably won't tell you. So that's a big thing we ask a lot about. And then action asthma plans, giving them empowerment. What do I do when I'm sick has been a pretty big help to us. So I put some of the references on there. I know you guys post these, and it's a good year to be a Buckeye. So, thank you very much.
Thank you. That was outstanding. John, thank you for that excellent review. I wanted to ask you about a couple of things, but I'm actually impressed how little molecular analysis has advanced asthma. We've seen tremendous advancements in lung cancer, even in IPF, where we're changing the classification of patients and it's affecting patient care. In asthma, we still haven't gotten there, so which is interesting. But I wanted to see if you could give us a couple of comments of GERD and asthma, and your success rate with allergy shots in adults.
Okay, so two. So kind of loaded on the second one there. So GERD and asthma. So that's an interest of mine. I'm part of the ALA, American Lung Association. I proposed a study, and we had a big study, the SARA study, looking at treatment of acid reflux in asthmatics. So we took a bunch of asthmatics. Everyone got a pH probe. We didn't randomize based on the results. They got one probe, and they either got Nexium at 40 twice a day, so esomeprazole, or placebo. I went into that, having especially been in pediatrics, convinced that GERD caused asthma, and these people were going to get better. At the end of 6 months, there was zero effect. And so, as I learned a new term, robustly negative trial. I mean, there was not even a glimmer of anything. So really kind of, I think, to me and a lot of other people, a shocking study, really didn't do anything at all. We replicated the same study, Jerry Teague, pediatrician at Virginia now, was at Emory, and little kids. We thought, well, the anatomy's a little different. Almost the exact same p-values, the exact same robustly negative study. When you look back at some of the other studies that have been done, there really wasn't that big of an effect. So my own opinion, or what I think the data suggests now, is that GERD does not cause asthma. GERD does not make asthma worse. Some people with GERD cough. Some people with GERD may have some respiratory symptoms. That's not their asthma. So in our population, we really looked at asymptomatic GERD, I will say that. So people without heartburn. Silent GERD, which is very common, we found 46% of asthmatics had a positive pH probe. So they did not have heartburn. We don't really understand why. People with heartburn, we thought, well, you're going to treat them anyway, so it almost doesn't matter. So I don't know if that's a separate population. My own opinion is it's not, but it could be. Can't tell you that on data. What I can say is that if the old guideline said if you had an asthmatic in your office with symptoms despite good treatment, you gave them an empiric trial of GERD therapy. There's no point in doing that anymore. You're wasting money and you're avoiding treating their asthma. GERD will not cause their asthma symptoms. I think that's pretty clear now. The second question about allergy shots, I'm fortunate our allergists are pretty conservative. I think there's lots of data. It's like 3-4 year data. I'm not exactly sure where it is. I kind of defer that to the allergists, but they don't put a lot of people on shots. They kind of do the conservative stuff first. And then with Xolair, I think that population were a lot of people who used to get allergy shots. So while I've not been a big fan of those in the past, my thinking is kind of thought, well, maybe they're dropping the IgE with these shots. So now it's a very small minority of my patients who have shots. So I kind of defer that to the allergist now, and it's not like they're cranking everyone on them, so I'm pretty happy with that. So I think there's enough good topical antihistamines, et cetera, to start first. For their asthma, if we can't put them on Xolair, then maybe they get their shot.
Good. Questions? Yes, sir.
Do you think that the reflex events that are occurring in the asthmatic process would be more abdominal pressure required to generate the inspiration and you're having that?
Yeah, so the question is, why do people with asthma have more GERD? That's certainly one of the theories, you're right. So people have hyperinflation, they get more negative intrathoracic pressure that has been shown to quote unquote suck the acid up. Some of the drugs, the beta agonists, the often we don't use so much anymore, but beta agonists release the lower esophageal sphincter, so maybe that's why there's more reflux. So there's several theories as to why asthmatics have more of this. I don't think anyone knows for sure, but certainly the pathophysiology of asthma is one of them.
You talked initially about how having the Th1 phenotype in molecular gamma is best associated with asthma. Is there any talk about like using interleukin 1 or interferon gamma for therapy of like moderate to severe asthma?
So using interferon for asthma, no, I haven't really seen anyone postulate that. So I don't know that I can comment on that one.
I read something recently, and I may not have understood it, so I can ask you to clarify. And you kind of touched on this a little bit about the long-acting beta agonist. If somebody comes under control with a combination of inhaled steroid and a long-acting beta agonist, should there be a trial after you gain control of discontinuing the long-acting and staying with whatever goes to inhaled steroid?
So that is the current recommendation. There's no data to support how should you do that. There was one study that was just published that showed, yeah, you can drop the beta agonist, and in most people they do fine just on the steroid, but exactly how you do that, nobody really knows yet. Our network's actually going to do another study in that area. With all the controversy and what people know, if I get people controlled on a medium dose combination, so medium dose steroid and long-acting beta agonist, and they're willing, I drop the beta agonist first and see how they do. And then some people do well, some people don't. If they fail, I just put it back on. I guess what I did say is no one should be on a beta agonist by itself anymore. That's now COPD, some people still do it. I don't. I just don't really trust the drugs by themselves. But in an asthmatic patient, even one with exercise-induced asthma, nobody should be on a long-acting beta agonist all by itself. That is, you'd be in a lot of trouble if something happens. It's just not thought to be a good thing anymore.
John, thank you very much.
All right.
Everyone, have a good day. Great talk. Very good. There's a gentleman here who probably wants to talk to you.
All right.